Good morning. I'm Dr. Shankar. I'm a consultant plastic surgeon at various hospitals in Mumbai. Having finished MCH in 1997, so that makes me like a veteran, 25 years in this field. Thank you, organizers, for giving us the chance to be part of this venture. Having said that, I'm a veteran. Obviously, I have younger colleagues who are much more in sync with what is required today. And so many of them are giving these competitive exams, and it takes, although you may be good at plastic surgery per se, it requires a altogether different skill set, I think, to be able to handle MCQ exams and sort of channelize everything and put everything right in your brain before you go in for these exams. So although I'm like some kind of father figure, if you will want it that way, I'm just around. But my fellow colleagues, Chetan and Prachir, they'll be handling, I think, almost everything. And they're very good at it. They know what is required, what the youngsters need when they need to appear for these exams. Here we are talking about MCQs. When you go for any exam, my understanding is that any competitive exam, at least post MBBS level, this for a social and preventive medicine is very important. There are always some 25-30 questions from that park and park. Similarly, I think when you do a plastic surgery exam, whether you like it or not, whether you're going to do burns for the rest of your life or not, there are definitely going to be few questions from burns. So I just thought it would be like a small curtain raiser if I just sort of gently take you through this. So the format will be that of course, you'll have a few clinical slides and this and that, but basically, as I go along, you'll see that we try to introduce more questions and giving you answers so that when you sit for the exam, you'll be more MCQ oriented. So the theory part, yes, it's an injury characterized by coagulative necrosis of tissues and thermal insult to the skin, causing a lot of changes in its composition. It kills cells, denatures proteins. Keyword here is coagulative necrosis. Come to the bottom of the slides, two factors extremely important: the intensity of heat and the duration of contact. So 70 degrees for 1 second can kill cells. Similarly, 44 degrees, it will take you 6 hours to cause the same amount of damage. Pathophysiology, basically we are talking about increased capillary permeability and increased evaporative loss of water. Now all this sets a huge cascade into motion, which manifests like this. So you have matrix proteins which are damaged and many cytokines flooding the circulation. Interleukin 1 and 8 being most important, along with this tumor necrosis factor alpha. So you have cell death, the endothelial vascular integrity is breached, transmigration of leukocytes take place, complement activation happens. All of this causes decreased tissue perfusion. Key figure to remember: what causes burn shock? You're talking about 20% TBSA. I'll come to this TBSA in slightly below, total body surface area. So it's always a little overwhelming if you try to understand that you are talking about 10% of the body getting burnt, but then you're going to have a whole shock-like system. Right? So how does all this happen? So you have fluid shifts happening 12 hours after burns, right? It's a process which starts instantaneously, as I already told you about this, interleukins, etc., flood the circulation. Capillary integrity in non-burnt tissues also participate. So there's the leakiness of the capillary endothelium, transudation of colloids, crystalloids, lots of things happen. So you have burn shock setting in, there is decreased intravascular volume, cardiac dysfunction, vascular changes. I just introduced one question here. Now, what is false regarding an immune response in burns? What is false? So basically what happens is you don't have a decrease in circulating catecholamines, you have an increase in catecholamines. So that is what causes the increased vascular resistance. The explanation is also given down below. I will not spend time reading this. What are the other systemic features that you see? You have respiratory involvement, metabolic, immunological, cardiovascular. I mean, every possible organ system is involved. Mainly in children, I mean, a question could be, what is the commonest cause of burns in children? So that the answer to that is scats. What is the commonest cause in adults? Usually flame burns. And all the other things can also cause burns. Few pictures representative. You have a friction burn there. Okay. Injury to airways and lungs. How do you go about this? one question. So, see, whenever you're in an enclosed space and you have a burn, a lot of toxic gases are generated, most commonly carbon monoxide and hydrogen cyanide. So what are the features of carbon monoxide toxicity? Now that's the question. And what would be the answer? It shifts the oxygen dissociation curve to the right. Now see, certain questions are sitters. Like 1 plus 1 is only going to be 2. It's not going to be 4. So certain things I think we just have to know. Like for example, the figure here, carbon monoxide has 250 times more affinity to hemoglobin compared to oxygen. But this is a figure you just have to know. Okay. What is the half-life? Now, how do you reduce this half-life of carboxyhemoglobin? Now, it binds to hemoglobin, it shifts the curve to the right. So now, what happens here? How will you decrease the half-life? By giving 100% oxygen. So the half-life of carboxyhemoglobin can be reduced by giving 100% oxygen to this patient. Okay. I already told you what are the other features of this poisoning. What does hydrogen cyanide do? It interferes with mitochondrial respiration and therefore causes metabolic acidosis. Features detailed here. Few pictures. Now, there is a question which says, what is the diagnostic feature? I mean, like, how would you diagnose upper airway involvement in burns? The answer is bronchoscopy. I'm just giving you the answer. Fine. How do you have, and what happens in burn shock? So there's an inflammatory reaction, vascular permeability, movements of water, solutes, proteins, etc. So beyond 20%, it's actually 20%, not 15. Sorry. Which of the following aptly describes superficial second-degree burns? What do you think would be the answer? So it is painful. There is desiccation. You have vesicles with the loss of epithelium. The answer to this would be, always read the question carefully, because when you're in this exam and your adrenaline levels are also very, very high, sometimes you miss reading that all except, and you then pick something else and come out. So the pathophysiological effects of major burn shock include all of these except. So you have increased vascular resistance, you have hemoconcentration, decreased glomerular filtration rate, but you don't have increased cardiac output, you have decreased cardiac output. Okay. And all the other physiological features which he has already mentioned: decreased pulmonary compliance, hepatic function is impaired, immunological functions are down, stress ulceration, Curling's ulcers, etc. One question could be, what is a new modality to know, which areas are superficial, which areas are second degree? So apparently laser Doppler flow meters will help to sort of solve this diagnostic conundrum. Other life-threatening events I've already explained. Basically every organ system is involved. You have to know what is important in each organ system. This is just completion of theory part. What is the best way to handle upper airway burns? They say early elective intubation is the safest and the best, because difficult. I mean, as you keep delaying it, it becomes more and more difficult. So carboxyhemoglobin greater than 10%. Now, apparently even smokers have this. It's always greater than 10% in them. But for us, when you do the MCQ, this is important. So as I said, bronchoscopy, gold standard for evaluation. So now, since there's a lecture on burns, I've just put this on for, completion of the flow. One take-home message: please pour water on burns. Instant. Why do you pour water on burns? It cools the burn, relieves pain, and then you replace fluid loss, etc. Definitely wrapping in the blanket is outdated, not to be done. You require a whole army of personnel to deal with burns. What do you do with blisters? So they say just puncture them, but do not remove the blister skin. So the figure on top, you see those huge blisters. The bottom one, you see that the blister is there, but we are just going to de-roof it. Okay, I'll take you to the next slide and come back to this. Question being, which zone of damaged burn tissue, as described by Jackson, is unresponsive to resuscitation? So we are basically talking about some zones which whatever you do is not going to come back to life. Let us look at it as like say cardiac tissue, myocardial tissue that once dead and gone is dead and gone. So which is that zone? It is a zone of coagulation. As we have already discussed, there is a central zone where there is complete coagulative necrosis of tissue cells. They are non-viable, they are dead, cells are apoptotic, and whatever you do, it cannot be salvaged. I mean, it's a goner. Okay. We'll come back to the other two zones. Which zone of burn injury is called the dynamic zone? So play of words here. The other word for dynamic zone is zone of stasis. So I'll just take you back to the chart, wherein here you have this representation of his burn model where he says this yellow zone or this central zone is a zone of coagulation, coagulative necrosis, everything is dead. Whatever you do cannot bring it back to life. That is surrounded by the zone of stasis, which is the dynamic zone. So if you adequately and promptly resuscitate the burn patient, this zone can still be converted into something which can be salvaged. So you don't have to excise that much when it comes to treatment. Okay. So which is the dynamic zone? It is the zone of stasis. So the description below tells you that it depends on the aggressiveness and promptness. As I already told you, you have to treat aggressively and quickly. And this zone can still be salvaged. It may not undergo coagulative necrosis, and therefore eventually you're dealing with a smaller burn area. Okay. How do you determine the extent of burns? Now, when you read this question, the first, your instinct tells you that this answer is Wallace's rules of 9, because that is what we've been taught. Okay, but the answer is the London Browder chart, because it's a more accurate method of estimation. I just put this charts here. Children are a huge different ball game altogether. So I mean, I'm not going to the differences there, but if you see this, the London Browder charting, it's much more detailed. I mean, in this Wallace's rules of 9, we know it as the upper limbs are 9%, the lower limbs are 18%, but here he breaks it down into smaller components. So hence, this is more accurate. Rough rule, how do you estimate size of burn? Palm and fingers approximately is 1% burn surface area. Okay. So question being 30-year-old sustains full thickness burns. So many things are just like bhel puri, a lot of additives. You focus on the important things. According to Wallace's rules of 9, what is the total body surface area of burn? Now for burns of both the lower limbs. So how much does that make it? Each lower limb is 18%. So 18 plus 18 is 36. Okay. Now you've finished estimating the area of burns. Now you have to take up how deep is the burn. So what is the depth of the burn? So there are chartings. Okay, what's the partial? What's the full thickness? Please read that at leisure. We'll have a few questions on that. Okay, now what happens in a superficial burn? Very simple. It's a sunburn. You just imagine all these foreigners going to a beach and having a sunbath. You just get a sunburn. Right? What do you do to it? You don't do anything. It just heals spontaneously. You can just have, example. Now next you have a superficial partial thickness burn. What happens here? Now the important thing is blisters. Question being, blistering is seen in. You have to know that the answer is superficial partial thickness burn. Here is a picture for that. Next category is a deep partial thickness burn. What happens in a deep partial thickness burn? Apart from all that theory, what you need to know is it is predicted to heal by 3 or more weeks. It's not going to heal. It could well heal spontaneously. Let me put it like that. Okay. Example. Let's give you a question here. Which of the following is true regarding deep dermal burns? Answer being early tangential excision is advocated. Now it may seem that, I'm sort of jumping. No, I'm not. I'm actually going quite chronologically. You will have to sort of set your mental thermostat that to know that you're supposed to have associations. You should know how to associate what with what. So when you do deep dermal burns, please remember that read the legend below. They usually heal after a prolonged period, most often with hypertrophic scarring. Therefore, early tangential excision is advocated for deep dermal burns. They are sometimes associated with blister formation. The key word here is sometimes. Okay, not always. Full thickness burns, anesthetic, do not blanch, charred, leathery. This is how it is. Okay, I already told you how do you calculate total body surface area of burns. When you do this calculation, you only take partial and full thickness burnt areas. Superficial burns are not included in the calculation. What is the gold standard to know adequacy of resuscitation? Urine. What urine output are you aiming for? Adults, you're aiming for at least 1 ml per kg per hour. Children, you're aiming for 2 ml per kg per hour. Okay. You're not very much concerned about CBP, BP, etc., etc. Please keep urine output as the gold standard. What is the most important fluid risk? At the end of it, when you're going for the exam, you'll have at least 100 names in your head. Okay. Now in burns itself, you have over 5-6 names. There are so many other topics where there are more names going to be added. So one name you'll take with you for the exam is Parkland's formula, described by Baxter. What happens in Parkland's formula? It is 4 ml per kg per percentage burnt. Okay. So the total body surface area burned into weight of patient into 4 ml. This is how you calculate the formula. So once you get, let us say, like 100 ml, you divide that into 2 aliquots. The first is given in the half of that is given, like 50 ml is given in the first 8 hours. Then you give 25 ml over the next 8 hours and then 25 ml over the subsequent 8 hours. So basically, I repeat, if you've calculated that this individual needs 100 ml, you give 50 ml in the first 8 hours, 25 in the next 8, and 25 in the subsequent 8. So there may be a question like this: 30-year-old man weighing 65 kilos. So what is the most appropriate fluid resuscitation regimen? We're going to give 4 ml per kg percentage of total body surface area burned. What is the fluid of choice? Finger lactate, otherwise called Hartmann solution. This man is undergoing active resuscitation. Which of the parameters best aids in titrating his IV fluid requirements, urine output? I already told you that. So finger lactate, Hartmann's most common crystalloid solution. Why? Again, one more name. Sometimes they may ask you hypertonic saline was popularized by. Now I have a small thing for this. Remember, Monaco biscuits is extremely salty. So Monaco is equal to Monafo. It makes your life a little easy. Okay, which all of the following formulae pertain solely to calculating crystalloid requirements in burn resuscitation, except Evans, because when you take Evans formula, he has added a little bit of colloid. It's not just a pure crystalloid formula. What are the other colloids you can give in burns? Whole lot of things you can give. Fine. Topical microbiome. There's usually always a question in this. What is the most important ointment which has excellent eschar penetration? So we all have grown up knowing that silver sulfadiazine 1% is the ointment to be applied for initial burn treatment. I mean, it was particularly a revelation to me also when I sort of read up for this lecture that apparently SSD, silver sulfadiazine, commonly called SSD, does not have very good eschar penetration. Apparently, sulfamylon 5%, or otherwise called mafenide, has excellent eschar penetration, kills pseudomonas, protects against suppurative chondritis, etc. Okay. So the question is, which has, I mean, if they give you a choice saying which is better eschar penetration, please choose sulfamylon, mafenide. Question. Answer. Okay, the answer is below here itself. So mafenide acetate 5% has excellent wound and eschar penetration. Okay. Which of the following regarding 1% SSD is false? Which is a false statement in this? It is not safe for use in pregnancy. Okay. What is the side effect of silver sulfadiazine? Common question, neutropenia or leukopenia. They say it's self-limiting, so you really don't have to fly into a flap and do something else. You just have to wait, it will settle by itself. Silver nitrate is another solution which is available, 0.5% solution. But it can cause a whole lot of medical problems, hyponatremia, hypochloremia, rarely methemoglobinemia, and just stains everything black. So I already made a point, and you've already seen, now we can connect these two slides. When you see that there is the zone of coagulative necrosis, the central zone, and we compare it to wound management. Now, it's a very common thing that the minute you get a burn patient, whether you resuscitate or not, there will be a huge list of antibiotics which are prescribed. And we have very many fancy things, tigecycline and piptaz. Do understand that there is a very small, or let me say, negligible role for systemic antibiotics, prophylactic systemic antibiotics. Why do they not have a role? Because the central zone of necrosis, which is called the eschar, is already devitalized and avascular. So the antibiotics cannot reach the area itself. So what purpose are you serving by giving these antibiotics apart from pushing up the patient's bill? Okay, so that's the wound management. See, these are various slides which we have done, and I've just put this in this presentation so that it gives you a gist of how the management goes. Okay, I just put this here because we have something called the boiled potato peel dressing. This is basically history of burn dressings which are available. What happens in an escharotomy? The same thing. You're just making an opening. As you see the central line there, which is running down the chest, the whole thing is opened. So this eschar, which was tight and constricting, when you make this incision, it opens up, and so it allows blood circulation. When you have circumferential burns, especially around the chest, around the extremities, it restricts blood flow. It restricts ventilatory excursions, and that is why these escharotomy incisions are important, because they will allow breathing, they will allow blood circulation. It's an escharotomy and not an escharectomy. The same way that you would say, let us say, tracheotomy and tracheostomy, kind of. Okay. Again, one more name you should know, feeding formula. Remember the first name, Carreri formula. Okay, caloric requirement for burns. Remember this figure. It's 60 kilocal per kg plus 35 kilocal per kg percentage burns. 1 plus 1, 2. Don't forget. Question here, who popularized tangential excision? So who popularized Nora Zanzikovic? Okay, lady. You have the same Carreri coming here. He was for nutritional requirements, as I told you. Our Monafo is also here. What do you do for tangential excision of burns? All are true except. So following excisions, split skin graft is applied at a later date. It is not applied at a later date. When you excise, when you tangentially excise, you are creating raw areas. You need to apply skin grafts immediately. Okay. Delayed reconstruction, eyelids get priority. In electrical injuries, basically anything below 1000 volts is low voltage, anything above 1000 volts is high voltage. Now why is this chart important? Now when any electric current passes through the body, it encounters many structures, nerves, blood vessels, muscles, skin, tendon, etc., etc. So the current very quickly flows through nerves, blood vessels, muscles, skin, etc., and encounters maximum resistance at bone. And wherever it encounters maximum resistance, there is extreme generation of heat. This is why it is important to know this. There's an MCQ on this also. Which of the following structures have the highest resistance to electric current? Bone has the highest resistance to electric current. There is one more question which comes here. Regarding compartment syndrome, following high voltage burn injury, what is the false statement? So the false statement is pulselessness occurs early and is diagnostic. That is the false statement. The legend below tells you all that you need to know. We are all aware of the 6 P's: pain, pallor, pulselessness, paresthesia, poikilothermia, etc. But pain on passive stretching is an early sign. Okay, pulselessness is a late sign. He also talks about this absolute pressure greater than 30 and pressure within 20. Now you have small instruments where you can monitor the intracompartmental pressure. I think the last two slides in this presentation shows you that instrument, because sometimes you can have an MCQ. They may just show you an instrument and say the above instrument is, and give you 4 choices. So that's it. So that's the electric current. Identify the following instrument. What instrument is this? It could be anything, but it is an intracompartmental pressure monitor. Okay. Electric burns. Okay. Chemical injuries. Questions being, certain things. Now you just have to know this, right? If you have phenol burns, what will you treat it with? You have to treat it with polyethylene glycol. Okay. Calcium gluconate is used as an antidote in burns caused by which of the following? Hydrofluoric acid. Okay, it's highly corrosive. Calcium gluconate, either you inject or you apply as an ointment. All are false regarding chemical burns. Please read this. Okay, alkalis cause liquefactive necrosis, acids cause coagulation necrosis. White phosphorus burns, what would you do? Just irrigate with water. Ionizing injuries, iodine tablets. Okay, that's it. Cold injuries. So what is the important thing to know about cold injury? We hardly see it in our country unless somebody has gone to Kashmir or, you know, to the Himalayas or something like that. So that's why our textbooks also don't deal with it too much in depth. But question is important. Now, regarding frostbite, all the following are true except. So what do you know about frostbite? There is definitely ice crystal formation. Systemic normothermia should be restored first. All this makes sense, just common sense. Now, should it be slow rewarming or should it be rapid rewarming? Surgery should be delayed until full tissue. So all of this makes sense. Where are you going to get stuck? You're going to get stuck in this slow rewarming. So it's not slow rewarming. It has to be rapid rewarming at 40 to 42 degrees for 30 minutes. Okay. So which of the following stages is correctly? So this you will just have to know. I mean, third degree you get hemorrhagic blisters. He's told you all the correct stages below. What in stage 1, what do you see? Stage 2, what do you see? What is that? 3, 4, etc. Okay, that's it. I think we've covered everything. Thank you.